So, good afternoon, everyone. So this is a case of a patient. So I'm presenting you a history of a patient 4 years back before the patient presented to us. He was a 26 years old male. He developed pain in both the hips 4 years back. He had associated stiffness of the lower back, which was relieved with physical activity. So this is a X-ray, plain X-ray of a pelvis showing both the hip joints. So this is a 4-year-old X-ray. Here we can see that the right hip is completely fused with bony ankylosis. There is a continuation of the trabeculae of the pelvis and the femoral head, which indicates the bony ankylosis. There is a osteoarthritis in the left hip joint. There is an ankylosis in both the SI joints. On further investigations, the patient turned out to be HLA-B27 positive, which is a marker of ankylosing spondylitis. The patient was on DMA-RDS since then. The patient underwent right total hip arthroplasty elsewhere outside 1.5 years back. There were no records why this plate was put, but it seems to have some intraoperative complications in the form of acetabular fractures, for which this posterior plating of this acetabulum was done. Further, the patient had a secondary osteoarthritis in the left hip, which we will discuss it further. So now this is the current clinical history of the patient. The patient presented to us with a gradually developed disabling pain in his left hip, which is increasing in intensity since last 6 months, since the period of lockdown. His activities of daily living were severely affected, and he is on continuous painkiller medications from the local physician. He presented us through online appointment on 17th October 2020. On physical examination, he had a severely painful gait with decreased stance on the affected side. Schober's test was positive. The right hip movements were fairly normal as the total hip arthroplasty would behave. On examination of the left hip movements, the flexion, there was a fixed flexion deformity of 10 degrees with further flexion up to 60 degrees, and it was painful at extremes. He had an abduction deformity of 10 degrees with further abduction up to 20 degrees. There was no adduction. He had a 10-degree external rotation deformity with further 10 degrees of external rotation. So this is the current X-ray of a patient. We can see there is a left secondary osteoarthritis of the hip, secondary to ankylosing spondylitis. So there are some features of secondary osteoarthritis as evident by there is a decrease in joint space, there are marginal osteophyte, there is a huge cyst in the head. So this is consistent with the findings of a secondary osteoarthritis of a hip with ankylosing spondylitis. So we planned the patient in the form of a total hip arthroplasty, which is the gold standard treatment for symptomatic end-stage arthritis. So what were the challenges we faced in managing this patient? This was an inflammatory disorder with disabling pain in the patient. The patient flew from another state from West Bengal. He does not want to go back without surgery. Moreover, there was an ongoing COVID pandemic while managing this case. So we explained the patient about the risks in the COVID times. We discussed various options to reduce the risk of COVID to the attendants by minimizing the hospital stay, by fast-track rehabilitation, and willingness and consent of the patient and the relatives for the same. We asked our anesthesia team to check and counsel the patient for the same. So I'd like to invite Professor Anjan Trikha sir for discussion about the anesthetic challenges. Thank you.
Thank you very much. The topic of ERAS is nothing new. It came into vogue about 10 years ago when in Europe it started in GI surgery specialty and GI medicine, and now it has taken over practically all surgical specialties. So orthopedics is one of them, and doing THRs under ERAS is a bit of a challenge in our country because of various issues which are not there in the West. Illiteracy and logistic and distances is one of them. If you see here, basically for ERAS and same-day total hip surgery, there are 4 players and 3 components. The 4 players are the patient, the surgeon, we as anesthesiologists, and the physiotherapist. It has to be a team effort of these 4 players and their teams, and then only the surgery goes ahead. And there are 3 components. The components, there is a small picture which I've taken from British Journal of Anesthesia. It talks about preoperative AD times, intraoperative issues, and postoperative issues. Preoperative, it is all about education, motivation, and this patient of ours was very motivated. Then it's about nutrition, and if you are following IRAS in your specialty, you will realize that the fasting guidelines have slightly changed. We would want them to be taking some clear fluid till about 2 hours, and they could even have some carbohydrate drink till about 3 hours. Solid thing, fasting remains the same. So once we take care of this, then we can really go ahead and think of discharging these patients. There are a big inclusion and exclusion criteria, so they are in front of you, especially for arthroplasty. Abroad, it is 70 years. I'm sure in India, it will be much less, maybe 60 years. And then as far as we are concerned, a status of 1 or 2, we hardly see a patient who's 60 years who would be in ASA status of 2. And primarily, this is only for unilateral hips or unilateral knees. Still, it has not been extrapolated to bilateral issues, and the rest is all there. More important is the patient, motivation, acceptance of risk, and the social support he or she has once he's discharged. Exclusion criteria are all there. They are very, there is no rocket science in it. It's all very common. We won't have these kind of patients coming for daycare arthroplasties. Now this becomes a bit of a challenge. We've been giving anesthesia for day in and day out for the last so many years. When I joined anesthesia, it was a patient who would regain consciousness maybe after about 6 hours, 8 hours, but now we've got switch on, switch off anesthesia. But a large number of medications are not really available in our country, and one of the most important is an opioid known as remifentanil. You switch it off, you close it, and the patient is awake after 1 minute. So with whatever we have available, we manage these patients with those, but our implications are in front of you. We use GA, you could have used spinal or epidural. There's a lot of controversy in that. But here what is important is that prevention of blood loss. So we give Trenexa, tranexamic acid as a routine. People have used it pre-op also as oral tablets. And equally important is the use of local anesthesia, which is more commonly given for knees, but in hips can also be tried. What is important is that, as already mentioned by Professor Malhotra, these patients should not be having nausea, vomiting, which becomes inherent part of certain anesthesia techniques. So the issues are multimodal analgesia, intra-op, and then post-op. For these patients, we gave a GA because we were doing a surgery for the first time. We could have given a spinal or epidural also with sedation, but we gave a GA, and our analgesia consisted of the shortest possible opioid which we have in India is fentanyl. But it becomes equally important as to what you do in the post-op, because if you remember, patient comes because he's not able to walk and it's painful, and he goes back because of pain. Goes back, and if he complains of pain, he comes back. So we use a multimodal analgesia. These are the drugs which are used, and I'm sure what you see new here is there are two as per standard recent guidelines. Now pregabalin and gabapentin is a very weak kind of evidence. As a matter of fact, a strong evidence of not using it pre-op and intra-op or post-op. And what is coming in is dexamethasone. Steroids are known to be anti-inflammatory. So a lot of surgeons all over the world are using it. We used it in this patient. However, it's a double-edged sword. For us, less of inflammation, less of pain. Plus it is anti-emetic, so less of nausea, vomiting. But for the patient, if he's a borderline diabetic, he could have his sugars going up and down. But I think in the near future, dexamethasone or any other kind of steroid is going to stay here as far as daycare, hip or knee surgery is concerned. Another thing which in India is very difficult to do is that we don't have opioids available over the counter which a patient can use if they go home. The only thing which we have is tramadol with us. Tramadol has its own problems. Nausea, vomiting, disorientation if a patient is old enough, and other issues. I don't know whether you are aware of it. We have codeine available with us in our country, 15 milligram tablets, slightly difficult to get. So that could be one of the rescue analgesics. For this patient, we let him go off on NSAIDs and tramadol and paracetamol. NSAIDs, last 15 years, I've seen a lot of surgeons telling us not to use it because they were afraid of increasing bleeding during the surgery, but now they have come back. So we use ketorolac, intra-op and post-op also, and then it was standard paracetamol and antiemetics. Thank you. Okay, the last one is a discharge criteria. This is our own criteria. You could see the video, you will see when the patient goes up, but we try to use this And what is equally important is that patient should have passed urine a couple of times. So that was one thing which we didn't use. A reason we didn't give a neuroaxial block, a spinal, or an epidural, because it's associated with a very high incidence of urinary retention. Many times the patient needs a catheter overnight, or many times he responds or she responds after you give a single decompression of the urinary bladder. So this is our own criteria. The patient fitted with these criteria, and we were able to send him back.
Thank you, Professor Trikha. So now I will discuss about how the change in surgical path made this case possible to discharge the same day. So there are different approaches described in the literature for a totalipatroplasty. The most common is the posterior and the lateral approach. You can see the patient lying in the posterior. For the posterior approach, the patient is in a lateral decubitus, and we approach through the posterior back of the hip, passing through the muscles to reach up to the joint. The approach we used in this patient was the direct anterior approach, which is a muscle sparing approach, going in between the tensor fasciae lata and the rectus femoris, without cutting any muscle directly up to the joint. Preparation of the acetabulum and as well as the femur does not require violation of any muscle play in the muscle bulk. So, and along with this advantage, we have an added advantage that during the surgery, we can see every steps in an intraoperative image. The first image shows the preparation of the acetabulum. The second image shows implantation of the acetabular cell. In the third image, the cell along with the preparation of the femoral component. And this is the image intraoperatively taken to confirm to see the final implants after the final implants. So the detail of this case is discussed, can be seen relevant in this 4 minutes video. The patient is coming early in the morning, the day of the surgery. He entered the operation theater in his own clothes. And then we had already counseled the patient, we had talked the patient regarding about this approach of the surgery, his intraoperative things, and his postoperative approach and follow things. He changed the clothes. It was early in the morning, so it seems that every patient is concentrated and every on the staff is concentrated on this. Since it was the first case, yeah, we had ample time to look after this patient. I can see the patient is lying supine in the approach to the anterior approach. This was the operating team along with this, with the surgeon, anesthetist, the nursing team, as well as the physiotherapist. By the noon of the day of the surgery, he was mobilized out of the bed. He is walking independently with the help of the walker. He has been asked if he has any pain. He is slowly mobilizing out of the bed and he got out of the operating the post-op room. I'm just showing this video because this shows all the things that we did in this particular patient and how daycare surgery is possible with a combined approach of four things, four components. So all those things that a patient is supposed to do after undergoing a total hip replacement is done in the same day. The same thing in the conventional approach the patient used to do a day later or a day after tomorrow, just like these things. The patient all those things were taught to him on the same day of the surgery. All those activities of daily living that is required for the patient was trained on the same day. Now he is being trained to walk out of the operation theater. In between, we are also asking the patient if he is having any pain, if he is having any dizziness, any problem associated with the surgery. So he was trained to climb the stairs. getting down of the stairs. We discharge him only in the tramadol and diclofenac. Okay, I just like to mention one thing. He had already undergone right total hip arthroplasty elsewhere, where some wrong thing happened during the surgery for his was plated, and he was not allowed to bear the weight in the same limb for 4 months. Now today, he is able to bear the weight, he is walking, he is pain-free. So out of no emotion, he asks to hug the operating surgeon before discharge. So this was the video we asked him to send on 7th of November after going back to his home. And this is the latest X-ray which is sent to us on 7th November. So what made this a special landmark? This was the first ever outpatient total hip arthroplasty performed in India, and it's a truly daycare surgery, not a 23-hour surgery, because in the literature there are different views. Some patients being admitted a night before the surgery and being discharged on the day of surgery, which is not a true daycare surgery. This was a true daycare surgery where the patient entered the operation theatre on the same day of surgery, on the same calendar day. The length of hospital stay was 0. It was done by less performed approach to the direct anterior approach, which is more suitable for the short stay, and the contemporary anesthesia techniques more suitable for outpatient total hip arthroplasty, that is ERAS, was used in this surgery. And this particular surgery was highlighted by the national newspaper. If you go to the literature, the most common surgical approach for the total hip arthroplasty are posterior and lateral. The journey of the direct anterior approach goes back to 1817, where Carl Hutter originally described it. It was later popularized by Smith Peterson in 1970. And the work of Juliet Brothers and Kegi helped to repopularize it after 1980s. There are certain advantages of performing a direct anterior approach, total hip arthroplasty. There are significantly low dislocation rate, less pain, and faster rehabilitation. Since no muscle will cut during the surgery, there is less inflammation, so it implies for less pain and faster rehabilitation, less incidence of pulmonary embolism and deep vein thrombosis, and less incidence of limb length discrepancy following the surgery. This surgery was performed in an ordinary table, though it is described that it needs a special table to perform the surgery. The reported literature suggests that the patients will have to stay less in the hospital or in the rehabilitation center following the surgery, which brings down the cost to $6,206, which is less than the patients undergoing surgery to the posterior approach. So if you come to the direct anterior approach in India, it is a newer surgical approach. It's not popular in India, but fast catching up elsewhere in the developed world. It is not followed by many surgeons as it is technically demanding, needs a special table and special retractors. It allows the patient to squat, sit cross-legged, or even sit on the floor as per Indian customs and culture, unlike any other approach used for total hip replacement. And is ideally suited for outpatient daycare total hip arthroplasty. So direct anterior approach at AIIMS, we have transitioned from a conventional posterior approach to direct anterior approach in about 50% in the last 1 year. We have been discharging patients within 24 to 72 hours of surgery after fully mobilizing them. So with this experience, we formed a team with anesthetists, physiotherapists, and decided upon the protocol to use this approach for daycare surgery. So if you go for a daycare surgery in Western world, it became popular because of the patients' own demand. They want to return to activities as early as possible and don't want to lose their job. It is cost effective, and the insurance coverage was less for our patients undergoing a surgery through a direct anterior approach, so that he was discharged early, so that the hospital cost was less. And the literature showed that there is no increase in readmission rates if patients were properly selected for this approach. The overall cost for outpatient was significantly lower than the patients in the inpatients group. So if you come for daycare surgery in total hip arthroplasty in India, it's an uncharted territory. The dogma that the patients need to stay in hospital to undergo surgery is still there. And still there are some surgeons fear because of inadequate mobility and independence to the patient, fear of risk of complications, dislocation, pain, wound complication, and stigma if there is a suboptimal outcome of the patient. So this very first case was possible in our setup because of proper counseling. The patient was well motivated and it was suitable during the COVID period. So this was a particular paper in 2020 only after this COVID pandemic. As you know, the most of the elective surgeries has come down because of COVID pandemic. But still the patients suffering because of disabling arthritis of knee and hip. Some will even endure a quality of life worse than death and may wish to proceed despite the high risk of mortality from contracting COVID in the perioperative period. And same was with our patient that he was trying to go back to the home and come back again after the COVID settled down. So if we have to talk about joint care during COVID in India, in research constant setting like India with limited number of beds, reduced stay means treating a greater number of patients with the same limited number of beds, enhancing efficiency and cutting down on the waiting list. Moreover, in the setting of COVID-19 pandemic, the patients will be treated on outpatient basis with minimum hospital stay. It reduces the risk of COVID-19 pandemic from others in the hospital, and the hospitals won't become the multipliers of infection. So the COVID-19 provided the perfect backdrop to launch outpatient total arthroplasty in India. So to summarize, fast track recovery and ERAs are the way forward for most surgeries, most notably in joint replacements. They have made daycare short stay joint replacement possible. Daycare total arthroplasty may help to solve the issue with high volume of patients with limited bed occupancy, especially in government setups. Current COVID pandemic provides the perfect platform to launch this surgery. Direct anterior approach has a lot of advantages to offer when used in daycare settings. However, proper selection of the patient is a must and teamwork is of paramount importance. I'd like to thank you for your kind attention.
We are happy to take any questions because I think the short duration, short stay joint replacement surgery is now the future. In the West, the driving force has been the cost of hospitalization because the beds actually are much more expensive than sending a nurse or the physiotherapist back to patient's house and take care of the patient's post-operative needs. But here, when we are working with long waiting lists and the resource constraint, the limited number of beds, the purpose is totally different, although we are doing the same thing, but with a different objective.
So we have a question from Mr. Yam Raman. Congratulations, very impressive. Any drawbacks, possible adverse effects of this approach?
Yeah, so there is a whole lot of complications which have been reported. There is a learning curve which is required, and you know, because it's not very popular because of the constraints, so the training centers for these approach are very few. Some of the complications of the traditional approach are taken care of here because you can see the component positions under X-ray, so component malposition is less likely. You can measure the limb length on the table, so the limb length discrepancy is less likely. So the biggest complication which people have reported is a fracture of the femur when you are preparing the femur, which is actually the most tricky part of the surgery. But once you have mastered that, you know, all other complications have been comparable or less than the conventional approaches, whether it's wound infection or and on the other hand, the dislocation rate is much less, the pain is much less, and across all the indications, the rehabilitation, compared to all other approaches, the dislocation rate is less. The other thing when we are talking about the technological advances is that if you want to do navigation or computer-assisted total hip replacement, there are very few systems now which can give you a good navigation system in a lateral position. So the next step of technological advancement where you want the computer-assisted surgery, again doing it in supine position with the direct anterior approach is something which is actually fast catching up in the world.
We have another question from Apandarjit Kaur. I think they have replied, sir, why is it not more popular in India despite so many benefits?
So a lot of surgeons these days have been going to centers abroad to try and learn direct anterior approach. But the first thing which they see is that most of the people who do it with a very special table. So that table costs about 2.5 to 3 crores. So when you come back, you don't have that table to operate it with, then that's a problem. The second thing is that the instruments which are required are also very special. So you don't get it. So we got these instruments made in India because they are very expensive. So when people come back after training, if they they are not able to do it because of the lack of specialized table or the specialized instruments, they very soon lose the drive to learn it. But here, the reason why we started doing it was purely eventually for a day when we will be able to send the patient home the same day. Even the learning curve or the number of cases required to overcome the initial learning challenges has been put somewhere around 15 to 30 cases depending on how experienced you are. But then what we want to emphasize here that this daycare surgery did not come in a day. Like it was said, we started discharging patients on third day, then second day, we switched over the approach to make sure that our patients were doing well, and then we switched over to direct anterior approach. The patients were having less pain and they were able to walk much faster and do those activities much faster. The only catch is that very severe deformities and very badly destroyed joints or very stiff joints, we would still tread with caution because those are not, because as you have seen, both for direct anterior approach and for daycare surgery, the patient selection is the key. So we are not here to prove a point, not to do it that the daycare or outpatient surgery can be done in every patient or the direct anterior approach can be done in every case. So you have to carefully choose your patient. That's where the key lies. You will not get a failure or a complication if you have carefully selected the patient. If there's any other question? Well, then thank you very much, everyone. Thank you a lot. Thanks a lot.